Okay. Hello, everybody. I'm Dr. Yu. Very thank you for joining us on this session. This session is heart valvular disease. I'm Dr. Yu from Taipei, Taiwan, as a cardiac surgeon. I'm so honored to be invited to host this meeting. On behalf of the APSC committee, I welcome all the speakers and audience to join the session. In this session, we are going to talk about several very important issues on heart valve disease, including the first one is from Dr. Yo, assessment of aortic stenosis and regurgitation by cardiac echo imaging. Yes. Dr. Yo, welcome to cooperate with me to host this session. Hi.
Hi.
And yeah, great. And after that, the second speaker is from UAE, Dr. Mahmoud Traina. Oh, his talk is regarding the bicuspid and the tricuspid aortic stenosis, how to do it by TAVI or surgical AVR or bento operation, something like that. I feel very, very happy to hear this. And the third speech is by Dr. Masanori Yamamoto from Japan. Yeah, to give us some talk about aortic stenosis and heart failure with reduced ejection fraction, whether to do medical treatment or surgical management. And the last one is from Dr. B from Brunei. His talk is the timing of surgical intervention for severe aortic regurgitation with low ejection, low pressure gradient. Okay, all these talks are very interesting and very clinically important. So to begin the first one, I first invite, I will host the first two speakers, and then Dr. Yo will host the third and the last speak. So let me introduce the first speaker, Dr. Yo Hui. Yeah, Dr. Yo is a senior consultant of cardiology. She's a director of echocardiography in National Heart Center of Singapore. Her talk is assessment of severity of aortic valve stenosis and aortic regurgitation by cardiac imaging, both for rheumatic and non-rheumatic etiology. Let's welcome Dr. Yo. Please, Dr. Yo.
Thank you very much, Chairman, and the organizer for inviting me to this very nice educational webinar with APSC. It is my great pleasure to be here, and I'm going to spend the next 20 minutes talking about the assessments of the aortic stenosis and regurgitations by cardiac imaging. I will focus a lot more on aortic stenosis because I think the errors as well as the measurements are very critical. You can see my slides well? I think you can, yeah? Okay.
Yeah.
I think,
yeah.
Great. Just need a bit of confirmations. Right, when it comes to aortic stenosis, I think we all know that degenerative tricuspid aortic valve disease is actually the most common cause of what we see today. However, when it comes to the type of aortic stenosis, it's important to ascertain whether this is bicuspid as well as whether rheumatic aortic stenosis is the other topic that I was given. So I will just take my time to go through this together with the rest of you. When it comes to the bicuspid aortic valve, we will hear later, the second speaker will talk a bit more about it, is to identify what is the pathology of bicuspid, whether it is no raphe with complete, it's just two clasps, or the typical ones that we see more commonly, which is type 1 bicuspid with one raphe, and usually 80% of that is a fusion of right and left clasp. This is important because it has implications for transcatheter valve therapy, especially in the area of TAVI. Now, I was given a talk about cardiac imaging for rheumatic as well as tricuspid aortic stenosis that is of degenerative. I think the important thing about degenerative aortic stenosis is that it doesn't involve the commissions. When it comes to the typical degenerative aortic stenosis, usually there's no commissional effusions and the free edge of the cast are not involved. And you see a very nice star-shaped orifice that is reduced because of aortic stenosis from calcifications or degenerations. This is in contrast to the rheumatic aortic stenosis, where you see usually a commissural fusion. And in this case, you can see effusions of the right as well as non-coronary cast. And typically you have thickening and there could be also calcifications. And typically you see rheumatic mitral stenosis as well because that's more frequently involved in rheumatic mitral disease. I think when it comes to evaluation of aortic stenosis, all of us depend very much on echocardiography, and we look at 3 parameters, and the most important parameters is that of Vmax, and then followed by mean gradient and aortic valve area. In this part of the world where the body surface area could be small, of course, a small habitus is important for us to index to the body surface area, such that in severe aortic stenosis, after defining or indexing to body surface area, is that of less than 0.6. And in ACC guidelines, it's important in our echo report to include that of a very severe aortic stenosis that includes a Vmax of more than 5 or mean gradient of more than 60 because it has got prognostic implications. Now, the problem with us sometimes in the echocardiography lab is that we need to really ascertain the highest velocity. Otherwise, we are going to underestimate the severity of aortic stenosis. And this is done typically by multi-windows interrogations of the jet. It is important to ensure that you get the highest velocity, and that could be not necessarily from the apical window. Any deviations of more than 15 degrees could actually underestimate the velocity, thereby underestimating the severity. In this case, as you can see, in the apical window, we have a Vmax of 3, but in the right sternal edge, when we do careful interrogations, you yield a velocity of more than 4 meters per second, telling us that it's severe aortic stenosis. At the same time, if you look at the CW of the Doppler signal, if you have a rounded shape, it tells you more severe than someone who has typical early peak of triangular shaped Doppler. So it gives us a sense of the severity when you make into comparison between the two. It's important as well that when we assess aortic stenosis, we do not take patients with subaortic obstruction such as that of Holcomb as a severe aortic stenosis, because this is not true. So it's just looking at a CW Doppler is easier for us to determine if this is subaortic Holcomb kind of problem or that of severe AS. The other parameters we looked at is the mean gradient. Mean gradient is important because it has prognosis implications, and in fact, it's the averaging of instantaneous gradients over the ejection period. So mean gradient measurements actually comes from the same measurement on echo and CW Doppler, getting the highest velocity and thereby getting the maximum CW Doppler. Usually, we do not need to correct for the proximal flow velocity unless the proximal flow velocity is high. For instance, in patients with high output failure or significant aortic regurgitation or sub-aortic LVOT obstructions, in that cases, you probably have to correct for that. Otherwise, you will overestimate the severity of true valvular aortic stenosis. The other errors that we do is that of the mistaking the MRJAC for aortic stenosis. So it's important that you looked at the envelope and that we only looked and assigned aortic stenosis at the ejection phase of the valve. Do not take mitral regurgitations because that could overestimate the true severity of aortic stenosis too. And then the last parameters we looked at in any report in echocardiography is that of aortic valve area. And remember, for aortic valve area calculations is through the continuity equation, taking into 3 parameters here, which is LVOT diameter, LVOT VTI, as well as aortic valve VTI. So underestimations of LVOT diameter actually is the commonest mistake, and this underestimate the true flow state of the outflow tract. So we do that very methodically in our lab. We have to ensure that you get the maximum LVOT diameter, which is measured from the inner edge, the inner edge of the septal endocardium to the anterior mitral valve leaflet. And usually in the patients with very severe dense LVOT classification, we may have to do a bit of altered view or off-axis view to yield the highest or the largest LVOT diameter. And this should be done during systole. And at the same time, if you do this correctly, any LVOT diameter that is within 1 centimeter of the aortic valve annulus tends to actually give you the same measurement as long as you open up the LVOT very well. The next parameters that's important when we calculate the continuity equation is that of LVOT BTI. It's important when we do sample volume placement of pulse Doppler is to avoid the flow accelerations. Once you actually calculate wrongly because of the overestimations of flow, and that will not be good for assessing of aortic stenosis. And the best measurements is just distal to the valve and the maximum laminar flow, and this will be the LVOT BTI that we plug into the continuity equations. I think it's very important to highlight that it's the effective orifice area based on the continuity equation that is the predictor of clinical outcome. In fact, the anatomy area may not be the best. I would like to summarize by saying that when it comes to aortic valve area calculations using the continuity equations, a lot of the errors actually comes from LVOT diameter. We should do it correctly, opening up as much as possible perpendicular to the axis of the LVOT and the aortic valve. The other measurements that we tend to also forget is that we have to do multi-window interrogation so as to avoid the underestimation because of the alignment of the jet. In our lab, usually we will assess in our report that to yield the highest velocity from either the apical or substernal window, such that we know the next time when we measure it, we should follow and get the highest velocity from there. And also the LVOT diameter is also in our report because usually do not change over time. Sometimes optimizing the windows may be really difficult. We take a ratio of the dimensionless index. In this case, we take anything that's less than 0.25 or 25%, tells you that's the most significant severity of the aortic stenosis. So I think it is a nice measure if you really cannot align the jet, apart from doing an invasive catheterizations. Telemetry also tells you a bit more about the anatomy of the valve, so it tends to tell you if the aortic stenosis is severe, and it is also a nice number of methods to assess aortic stenosis if you can't really get the highest grade. I think the recommendations from the guidelines is really an optimizations of LVOT assessments and BTI. The next thing that really is another conundrum when we manage patients is that of low flow, low gradient aortic stenosis with reduced EF or preserved EF. I think I will speak a bit more about that because it's important for diagnosis of severe aortic AS in this group. By definition, what does low flow, low gradient AS means? It means that when you have a discordant in terms of calculated aortic valve area of less than 1 centimeter square, and however, the mean gradient is less than 40. And this would happen because of the low flow state, because of reduced LV systolic function, or because the LV cavity is too thick that the flow is actually reduced. The question then is AS severe that you want to render for patients to subject to an aortic valve intervention? So in this case, for example, you have patients with severe LV systolic dysfunctions, and then the questions you have for yourself is this true severe aortic stenosis because of afterload mismatch with LV dysfunctions that you want to offer aortic valve intervention, or is it an LV dysfunction with concomitant non-severe aortic stenosis? So these two you need to tease out because you want to offer surgery or an aortic valve intervention such as TAVI. In this case, you have case one, the patient with very severe LV dysfunction after calculations of the aortic valve area, even by index is severe. However, the mean gradient is less than 40 and the Vmax is 3 and not more than 4. The second case is that of bicuspid aortic stenosis, and in this you have patients with again LV dysfunctions and the calculated aortic valve area is 0.8 and even index is less than 0.6, so it's severe by definition, yet the gradient is 32. So what would you do? As I said before, it's important to ensure that all measurements are done properly. In this case, getting the highest velocity, it may be from the right sternal edge or supra sternal edge, and that it already gives you a severe aortic stenosis by definition, then there's no need to go for further measurement. Otherwise, a low flow, low dose dobutamine strength will be the next things we do. The whole purpose of increasing the dobutamine is to increase the forward flow. To increase the forward flow, you hope that the velocity will be higher, and if it's severe aortic stenosis, the jet will be higher than 4 meters per second or V gradient of more than 40. However, the aortic valve failure do not exceed 1. So in that case, it will be true severe stenosis. However, sometimes because of LV dysfunctions or where there's no contractile or flow reserve, you can't tell either whether it's true severe or just concomitant non-severe aortic stenosis. In that case, the flow measurements from dobutamine stress do not help you. So we go to the next measurements, such as that of calcifications of aortic valve. If the calcium is very calcified, in this case that is seen here on the right panel, then you know that this is very severe aortic stenosis. Now, by definitions, a woman with anything less than 1,002 on calcium score of the aortic valve, or men less than 2,000 is not severe, but above this is considered severe. So we go back to our case number 1. We've given the low flow dobutamine stress, and we are able to increase the flow to more than 20%. That will be enough of what we call flow reserve. However, the mean gradient do not go beyond 40, and the Vmax is only 3, and we are able to open the valve just above 1. So these patients we actually waited for a while, and to confirm that the aortic stenosis is not yet severe, we actually did a calcium score, and indeed it is just a female. She do not have true severe aortic severe stage. We watch her very carefully. Actually, 6 to 9 months later, she becomes symptomatic, and she actually went on to go for an aortic valve interventions for TAVI. The second case, the bicuspid aortic valve, which you probably remember, in this case, we actually increased the dobutamine to 20, and by then we have managed to increase the stroke volume above 50, and then we have also derived a velocity above 4, and a gradient above 50. So he has a severe aortic stenosis, and then she was given TAVI, and she actually recovered very well with almost normalization of the LV dysfunctions. The next possibility is that of a paradoxical low flow gradient AS with preserved or normal EF. This can happen because, as I said before, because of hypertrophy of the LV and small LV cavity. However, in this case, not only you have to assure that the measurements are correct, usually we look for other possible causes, such as if there is a significant mitral regurgitation or tricuspid regurgitation or stenosis, the forward flow across the aortic valve is reduced, and that could explain the reduced in stroke volume. So again, paradoxical low flow, low gradient aortic stenosis is actually one of the hardest for us in the lab to ascertain whether it's severe. Sometimes even increasing or doing dobutamine stress may not help because of such a small LV cavity. Augmentation of flow do not happen despite dobutamine. So what we do is we actually can do calcium score again, and using the same cutoff, we can identify whether this is severe or less severe aortic stenosis. Sometimes the guidelines actually recommend that we have to verify the flow across the valve by looking whether is the stroke volume really reduced. So we do other multi-metric approach of looking at the stroke volume using either 3D echoes or a CMR to ascertain that this is truly a low flow state because of low volume. I think I just want to summarize before I go to aortic regurgitations that in aortic valve calcifications, it's very helpful, especially in a patient with low flow, classical low flow, low gradient aortic stenosis with reduced EF, where you don't see a flow reserve, you can't tell after dobutamine stress, or in patient with preserved LV dysfunction, with preserved LV function, sometimes you just can't tell that a calcium score can help. This is a case of a rheumatic aortic stenosis, where you see a rheumatic mitral stenosis. And then in this case, you can see that the mean gradient is 40 and the Vmax is the 4, and severe stenosis is both confirmed with hemodynamics as well as the valve area. However, if you do a calcium score on her, you actually do not have very high calcium score, telling us that in aortic valve calcification score assessments of aortic stenosis is only applicable for calcific aortic stenosis and not so for either inflammatory or rheumatic fibrotic aortic stenosis. With that, I would like to just spend the next 5 minutes on the assessments of aortic regurgitation. I think Dr. B will talk more about it. Suffice to say, when we assess aortic regurgitation, we have to look at the etiology as well as the reasons or mechanism of aortic regurgitations. The next thing that we normally do for aortic regurgitation assessment is that of Doppler, and I would like to just highlight the importance of looking at the flow conversions where you look at the vena contractile wave, because vena contractile in aortic regurgitation is very helpful. It is probably the more reliable parameters that I depend on because it's independent of the flow state as well as the driving force. So it's useful to measure that to give a set assessments of whether the aortic regurgitation is severe. And of course, if you have multi-parameters to suggest it's severe, then it's quite consistent. However, sometimes you may have in between and you're not sure whether you're dealing with aortic regurgitation. And that's the important role of doing a TEE in AR assessment. In TEE, you can assess the aortic regurgitations more clearly, and especially as in patients with acute AR, sometimes the flow in the regurgitation can be very acute due to equalization or rapid equalizations of the pressures that the flow is not present anymore. But if you do a TEE on them, you can see that the aortic regurgitation is very severe. Not only that, you can assess the morphology of the aortic valve. For example, in the right panel, the aortic regurgitation is not probably just moderate, but it is a morphology of that of 4 leaflets of aortic valve. It's quite rare. Without that, we are not sure what we're dealing with, and yet the aortic dilatations are not present, so we couldn't explain why the central regurgitations. The next thing is, of course, planning for any surgery such as valve repair is important to look at the anatomy of aortic valve. For example, in this case, this is an infective endocarditis with masses that has destroyed the non-coronary cusp. In this case, you can see perforations. Lastly, I think we should not forget that there are other cardiac imaging such as CMR that allows much more accurate assessments of the aortic regurgitation. In this case, both the aortic valve as well as the root anatomy, as well as the aortic regurgitation quantification and severity, because CMR allows you to do phase contrast velocity coding kind of mapping to allow for the measurements of forward and the backward or the leakage. And that tells you the regurgitation fractions. We can indicate the severity of aortic regurgitation. It's also helpful to look at the LV dimensions of the patients with chronic aortic regurgitations, as well as the status of an aortic root anatomy. So in my mind, I have to ask myself, when do I refer to CMR for AR assessment? I usually do that when I have suboptimal echo windows or in a patient with severe, or I suspect severe aortic regurgitation and with multiple aortic regurgitation jet or eccentric AR that I know I'm going to get underestimations from aortic regurgitation from echo. And this kind of scenario or any discordance between clinical and echo findings, I'll refer them to CMR. I think with that, I thank you very much for your attention, and it's nice having to see all of you in this webinar.
Thanks very much for Dr. Yo's very informative and very clear talk about several images in aortic valve estimation. Before any question from the audience, may I have the first question? I heard you talk about the CMR to estimate the quantification of aortic regurgitation. Do you, in your experience, do you have a reference guideline comparison between CMR quantification for the degree of aortic regurgitation and that measurement done by the echocardiography?
Thank you very much, Professor Yi, for these questions. I think it's always an important clinical decision making, whether who we should trust, right? So I have an experience a few years ago looking at aortic regurgitations and what sort of aortic regurgitations will correlate well with CMR and those who do not. So my experience is if you have central aortic regurgitations, the PISA quantifications as on echo seems to correlate quite well on CMR, which means that you can trust your echo measurements, whether that is by quantitative methods on the PISA quantifications on echo, on 3D echo. The other possibility is that of eccentric aortic regurgitation, that by PISA quantifications tend to underestimate based on the echo.
Yeah.
So I do not actually trust PISA quantifications on the eccentric jet. If you go on to do CMR, you think that you will underestimate because of the fact that in CMR, you actually can directly measure the flow before and leaking. And then I have the opportunity because I actually looked at 3D and whether 3D can help doing a vena contractile by 3D. And it seems that it can correlate a bit better, certainly better with respect to the central AR rather than eccentric aortic regurgitations. So either you move on to CMR for eccentric AR, or if you would like to do 3D, but 3D is not as easy for transthoracic. If you want to do 3D, you have to go to 3D transesophageal. I hope that helps.
And in the hospital I serve, I work in the National Taiwan University Hospital in Taipei, Taiwan. The regular clinical practice for the aortic valve regurgitation, once studied by echocardiography, usually we do the CT, and very seldom we will do MRI. And may I ask, what's your opinion about the echo, CT, MRI in clinical practice in your hospital?
Thank you for the questions again. Now, for us, we don't do CT routinely for CMR assessment because CT actually looks more for the anatomy of the aortic valve and the root. To do quantifications on CT, especially the LV chamber size and the function, I think you have to deal with, a lot more of either contrast or radiations. So we don't use it on the routine basis. We do that for aortic regurgitation on CT to look for complications of the infective endocarditis, because that's much more clearer with better spatial resolutions compared to, say, for example, CMR. So if you have to look at anatomy, sure, I go for CT. But if I look at hemodynamic of the LV dilatations, as well as AR assessment, then it will be unfortunately a CMR. So in a hospital such as mine, I come from a public hospital, we have to be careful what sort of modality and where you want to place your money on. It is really one modality that you think will decide on the management plan. So for an asymptomatic aortic regurgitation, I normally follow them up. If I can't get a good assessment on echo, I will do a CMR. And I may have to do every 6 to yearly CMR to look at the LV dilatations if echo is the limiting imaging to assess properly. But if I have to do that just because I wanted to plan for surgery, for example, aortic valve repair or aortic root repair, it will definitely be a CT, because the CT gives me the answer quite straight away, and I think the pictures are excellent. And money-wise, it's a little bit cheaper.
Yes. Because I'm a cardiac surgeon, many of my case is referred for possibility of aortic root repair, something like that. So we do a lot of CT. May I ask a question? How, when regarding the aortic valve repair, what parameter will you measure by echocardiography? I mean, annulus diameter, the height of commissure, the sinus tubular junction, something like that. Do you have any comments?
Well asked questions. In fact, I think this is something that is actually in my hospital that the surgeons are asking us, and I actually tell them, you tell me what is important for you, because we have to cater to what you need. So a commissure's kind of measurements and the cast length is something that they would like us to measure. I don't put it in my talk because I think that's very, very specialized and only in expert center. I think it really depends on what you guys want, and you work with the imaging colleague, what is best. So I don't have really very much experience with it. We have a few cases, but I think maybe the second talk or the second speaker could address some of these questions.
Thank you very much. Thank you again.
My pleasure.
For the limit of time, I have to close this session. If no more questions from my audience, sorry to occupy too much of time. Okay. So let's move to the second speech. Second speech is brought by Dr. Mahmoud Traina from UAE. Dr. Mahmoud Traina is a clinical professor of medicine in Cleveland Clinic. Also, is now a director in cardiac cath lab and the Heart and Vascular Institute in Cleveland Clinic in Abu Dhabi. Dr. Traina brings us a topic about assessment and the interventional management of a severe tricuspid valve and the tricuspid versus bicuspid aortic valve stenosis, whether both either done by TAVI, SAVR, or bento operation. Please, Dr. Traina.
Thank you so much, Dr. Yu. It's my pleasure to be here. Thank you. Thank you for the introduction. And I'm very happy to be joining you all today and hopefully can add something to this session. So I'll be talking about the kind of how we evaluate and management of patients with aortic stenosis, both tricuspid and bicuspid, in terms of our decision-making of transcatheter approaches versus surgical approaches. So I have no disclosures relevant to this talk. And as we all know, there's a huge burden of aortic stenosis, with the vast majority of these patients being low risk. But up until recently, and especially with the advent of TAVR, very low percentage of these patients were getting to surgery and to operation. This is just one series from around the time of the first partner trials, shows that across 10 centers, 950 patients with severe AS, only half were getting referred for surgery, and of those, only about 40% were getting had surgery done. And this was seen across multiple series. There's a huge unmet need of patients with severe aortic stenosis out there for various reasons that aren't getting referred for intervention. Now, if we look at where's the spectrum of evaluation for patients with TAVR, the first trials, obviously, as we all know, were the partner trials that were done in 2000, that were presented in 2010 and 2011, starting with the partner 1B, which looked at patients that were inoperable and showed that TAVR had a significant 50% reduction in mortality compared to standard therapy, which is nothing at that time. Second part of partner was the partner 1A trial, which was the high-risk group, and again showed similar death with a trend towards reduced death with TAVR compared to surgery. Now, so this led to a very increased use of TAVR in these populations, but one of the important things, and when we discuss, again, decision-making, and we could have added a fourth group, is TAVR, SAVR, Bentall, or nothing, is what point is there futility and what point does it become too late in terms of predicting outcomes? Now, frailty has been found to be a very powerful predictor of mortality across all the trials. This is an analysis from the partner 2 trial, showed that just frailty, independent when controlled for other factors, increased prediction of mortality. And frailty was a poor prediction of outcomes, both in the TAVR and the SAVR populations, as you can see on the table here on the right. And so there's been multiple risk models, but as makes sense, if the patient goes in a very poor status, they tend to come out in a poor status with both TAVR or surgery, whatever you treat the patient with, and it's not going to fix patients all their situations. So patients with poor functional status, poor quality of life, relatively low mean aortic valve gradients, lung disease and kidney disease are particularly high risk of post-procedure low quality of life. So how do we evaluate patients with severe aortic stenosis? So obviously the first step is multimodality imaging. So the key cardinal features are echo, CT, and coronary angiography, kind of to get a true understanding of the anatomy and the disease process. Then we evaluate by a multidisciplinary team, and fundamental to that evaluation is really obtaining true numbers, so Euro score, STS score of the patient, anatomical factors, looking at their comorbidities, And through the multidisciplinary heart team, which involves the cardiologist, the surgeon, the imaging cardiologist, and the anesthesiologist, make a decision about which way each patient can go versus surgical or transcatheter approach. And if it is transcatheter, transfemoral, which is the ideal, or need for alternative access. Now, as we're all aware and was mentioned previously in previous talk, when we assess these patients with aortic stenosis for therapies, cardiac CT has really become the cardinal feature after echo in terms of assessing. So we can be able to assess the annular dimension on the CT, we can assess coronary height, the calcification. We actually can get a better assessment of whether it's bicuspid or tricuspid. It's often missed on echo, where you can't really tell with the calcification. You get a true exact delineation of that. And we get a very good delineation of the iliofemoral anatomy, so that which is essential for evaluation of patients for potential TAVR. Now, when we're talking about these high-risk patients, it's really important to have a true framework for TAVR assessment. So when we look at the heart team, we have to look at we have to analyze what are the potential anticipated benefits for the patient, what's their underlying clinical risk, what's their geriatric risk from their other comorbidities and frailty in general, and the patient's goals and preferences. And I think there's a scope of patients where, when the benefit is high and the risk is relatively low, where we want to target TAVR, but at some point the benefit to the patients in the severely frail and severe comorbidity patients, where the discussion often has to be done about, are we pursuing a futile course? And I think that's very important in when we talk about these very high risk or advanced cases. So following the high-risk patient trials came the intermediate risk trials, and that was with TAVR was then the PARTNER 2 trials. And in that was, if we looked at the overall intention to treat population, showed a similar outcomes in surgery versus TAVR using the SAPIEN XT valve when we're looking at hard endpoints, death from any cause or disabling stroke. But if you look just specifically at the transfemoral cohort, which was a pre-specified cohort, actually TAVR shows superiority to surgery in that group. So I think this is the trial that really showed us that femoral access TAVR is the optimal approach, and any other approaches would be transapical, which is probably the worst approach, versus transaortic or subclavian or even transcarotid are secondary approaches when transfemoral is not available. So during this time also, there's been a lot of development in terms of the device ability with these delivery of these devices. So we've been able to go from 22 French in the initial SAPIEN valves down to 16 French with the XT, and down to 14 French with the SAPIEN 3 valves. So smaller delivery systems, purely percutaneous, improved procedural techniques and access techniques to improve bleeding complications and other procedural complications. And so a much wider range of valves allow treatment of a lot more patients. This is a registry trial, so it's a little bit, hard to kind of look at, but this took patients treated with a SAPIEN 3, so the third generation SAPIEN valve, and had a case match controls to the PARTNER 2 trials. And we show that in this registry comparison case control study, showed that TAVR had an improved mortality compared to surgery, along with a reduced stroke rate. And we see that across the board with the trials. As technique has improved and as technology has improved and worldwide experience has improved, mortality with TAVR has decreased from as high as 6% in the early PARTNER trials down to the 1% to 2% range with current SAPIEN 3 registries. Similarly, stroke rates, as again, technique and procedural devices have improved, have also decreased from where it was a particular concern in the first PARTNER trials of over 5% to 6%, down to 1% to 2% with current generation SAPIEN valves. We also see similar with the self-expanding valves in the SURTAVI trial for the intermediate risk patients, showed again similar outcomes for death or stroke rate with TAVR as compared to surgery. with a caveat that with this issue, we do have higher rates of vascular complications with percutaneous approaches, and particularly concerning with the earlier generations of self-expanding valves is a high permanent pacemaker rates. 25% is reported in the Certavi trial. Now, one of the important issues that come up with TAVR approaches is paravalvular leaks. So this is kind of from the partner trials looking at the presence of paravalvular leak and prediction of outcomes. And it's not that, it's not a benign finding. So paravalvular leak is a very malignant process. And even the presence of mild paravalvular leak conferred a almost 50% increased mortality versus none or trace. And moderate to severe paravalvular leak more than doubled mortality in patients. So this is an important issue when planning and deciding in TAVR, and especially as we start talking about lower risk patients, is to avoid that paravalvular leak. Now, as the technology has improved with the self-expanding valves from the initial core valve to Evolut R followed by Evolut Pro, the rates of paravalvular leak have also dramatically declined, where only a quarter of patients have mild leak and very rare to have moderate or severe leak in this study. Similarly, again, we see the same thing with the SAPIEN valves, is that the rates of paravalvular leak in the partner trials has dramatically decreased from where we were having rates of moderate to severe paravalvular leak of 11 and 12% in the partner 1A and 1B trial to 1 to 3% in more recent iterations of the data. An important concern as we again try to consider patients with lower risk is the durability of the valves. So are these valves as durable as surgical valves with TAVR valves? And at least to date, with the data we have from the partner trials, shows that the valves are very durable out to at least to 5 years, and more recent data out to 8 to 10 years, approaching those or equal to those of surgical valves in terms of gradients and in terms of failure rates. So when we start discussing TAVR potentially in lower risk patients, what are the outcomes that we need to meet? We need to be able to achieve very low risk data as surgeons have been able to achieve with these low risk patients over the years. So benchmark of mortality of 1%, stroke rates of around 1%, lower the vascular complications below 5%, avoid permanent pacemakers and have it less than 10%, and dramatically reduce moderate to severe AI. Now, these are the outcomes of the two largest low-risk trials. So the PARTNER 3 trial was with a balloon expandable SAPIEN valve and showed a reduction. This time, with the data included rehospitalization. So death, stroke, or rehospitalization showed a significant reduction with TAVR, primarily driven by the rehospitalization outcome. In the Evolut low-risk trial, again, looking at just hard endpoints, death or disabling stroke, there was a trend towards reduction in events with TAVR valves. And if we look at a meta-analysis of the low-risk trials, so which include the Certavi, the PARTNER 3, and Notion and Evolut low-risk, the overall meta-analysis favors TAVR in reducing mortality. So lower mortality with TAVR as compared to surgical AVR. This is all-cause death, reduced cardiovascular death, and trends towards reduction in stroke and MI. Now, it's an important caveat. So does this mean that we send all patients with aortic stenosis for TAVR? And I think this is often missed, is what are the exclusion criteria and what was excluded from these trials? So across the board, bicuspid valves were excluded from these trials. Iliofemoral disease, significant iliofemoral disease that prevented transfemoral access were excluded from these trials. Complex coronary artery disease were excluded from these trials. So I think it's very important to understand which patients were included. And the mean age of these patients, even in the low-risk trials, was 72. And so younger patients were primarily either excluded with a cutoff age of 65 in the PARTNER 3 and the Certavi trial, or were rare in these trials. And when we start targeting these therapies in younger patients, that's important to recognize. Now, what are some examples of high risk anatomical features? So low coronary height, for example, as you can see in A and D, is an important issue with TAVR leading to possible coronary obstruction. Bicuspid valves with calcified raphe and heavily excess leaflet calcifications, a high risk anatomy. As we look on the C and F pictures there, presence of severe LVOT calcium. So when that's a risk for rupture and complications with TAVR valves are important to evaluate. So when we're making these decisions on these patients, we can make a blanket approach to all the patients. So I'd like to spend a little bit more time in these next few minutes just talking about bicuspid aortic valve. And like I mentioned, bicuspid valves were excluded from all the pivotal low-risk randomized trials, and even the intermediate and high-risk trials, they were excluded. And there's certain features about bicuspid valve that make it more challenging. So the annulus tends to be more elliptical. The distribution of calcium is asymmetric. They often have bulkier calcification and extending into the LVOT. They tend to have lower coronary heights. And of course, the presence of ascending aortic dilation, which may need to be managed surgically. So when we look at bicuspid aortic valve, the classic description is in the Sievers classification, where we group them into type 0, type 1, and type 2. Type 0 having no raphe. True bicuspid valve, it's about 7% of patients. Type 1, which is the majority, where we do have a single raphe, and then type 2 is where we have 2 raphes. So TAVR has been done, though it's not in a randomized trial. There is a registry of bicuspid aortic stenosis that have been done by TAVR. And when we look at the simple on the right, all-cause mortality is similar. Again, these are pre-selected patients. So they're evaluated and decided for TAVR. So it can be achieved with reasonable mortality that approaches what we see with tricuspid AS. But if we look at the table on the left, the rates of complications are higher. So the conversion rate to surgery is higher. The rates of aortic root injury is higher. The need for a second valve is higher, and the rates of paravalvular leak are higher. So longer term outcomes may be worse in these patients, and we need to really evaluate which patients will be considered for TAVR. Now, some of this was driven by earlier generation devices. So if we look at the earliest generation devices, the rates were higher for paravalvular leak and device failure and need for pacemaker. As newer generation devices have come out with the SAPIEN 3 and the Evolut Pro, and technique has improved, higher implantation has become a standard, I think, mostly worldwide, with all the valves have led to lower rates of pacemakers and lower rates of paravalvular leak. So there's a lot of variability in bicuspid anatomy, and I think when we can get into it, it becomes a lot of description. So not all type 0s are the same, not all type 1s are the same, and becomes a little bit complicated in describing them. But I think I like this this table from Yoon and Makar, and I think it kind of provides at least from a management issue, a more simplified way of looking at these patients when we look at bicuspid valves in a phenotype, so a clinical phenotype. So where we look at, first, do they have a raphe? Is the raphe, and then is the raphe calcified? And second, what's their degree of leaflet calcification? Is it mild or is it excessive? And this is kind of can group patients into key clinical factors, which I'll show you makes a difference in terms of decision making. So those that have mild leaflet calcifications can be considered. Those that have excess leaflet calcification, especially when combined for a calcified raphe, are the patients that do poorly with TAVR. And this is kind of shown in their registry, in the same registry of 1,115 patients. If they just have one of those two features, so either just a calcified raphe or excess leaflet calcifications, they approach the outcomes of those that don't. But if you have the combination of those two features, those really do the worst long-term with TAVR. And they have higher rates of paravalvular leak, more aortic root injury, and those are the ones that have the higher mortality overall. So just to give you an example, this is kind of how we look at it in our heart team approach, and we prepare for all our TAVR patients, is we kind of create this chart where we kind of summarize all the key fundamental features. We look at the patient's history, their STS score, their laboratory findings, their echo and CT findings and cath findings, and kind of discuss them in a multidisciplinary manner about optimal approaches. So this is an example of a case we did with a 74-year-old with multiple comorbidities and frail, with a STS score in the intermediate range of 5%, not a good surgical candidate, had severe aortic stenosis, but on the anatomy had a low coronary height, and which was an issue, along with a small valve that we decided, based on her surgical risk, to go ahead with TAVR. So this is, again, if I had to put one point of emphasis in the decision making of these, is heart team is critical in making any of these decisions. So what are the factors when we look at, there's multiple factors that look at coronary obstruction risk and how we decide the length of the leaflets, where's the calcium located, where's the coronary ostium, and how big is the sinus. These are all helpful features that kind of evaluating the patients, but often when the decision is made, the proof is in the pudding. So this is that patient with, again, very severe advanced aortic stenosis, high gradient, mean gradient over 60. And when we look at the anatomy, again, you can see here on the left, there's a very low coronary height, which is concerning and an issue, but the sinuses are relatively large. We do a pre-dilation in these cases, where we do a balloon to try to see if the leaflet, if we deflect the leaflet up, does it affect the coronary? And we can still see over there on the left that the left coronary is filling, but it's a pretty small channel. So in a case like this is a case where we decided to prep for a potential obstruction in the case and place a stent into the coronary to have it ready in case there's a coronary obstruction, which would be an immediate and emergent situation. So there's an Edwards sapien valve placed. We positioned it a little bit lower than we normally would. We tend to be at about a 90-10 position on most of these cases. This one we placed a little bit lower, again, given the coronary location. Deploy the valve, afterwards tolerated it well, and was able to keep the coronary state open and did not, luckily, need to deploy the stent in this case. Had good hemodynamic response and did well. So this is, again, but a high gradient because I had to use a small 20-millimeter valve. So in summary, I think the key with all these decision makings in terms of TAVR versus SAVR is a well-functioning multidisciplinary heart team is really the most essential aspect for optimal decision making for each individual patient. High quality multimodality imaging with echo, CT, and coronary angiography are essential to guide the treatment decisions. In general, increased surgical risk and comorbidities, as reflected in increased STS and Euro scores, or frailty, tend to favor TAVR. The presence of higher risk anatomy, severe femoral disease, low coronary, high LVOT calcium, the presence of dilated ascending aortas, especially in the setting of bicuspid valves, generally favor surgical aortic valve disease, and these were excluded from the pivotal trials. I think that's important to recognize. Bicuspid aortic stenosis was excluded from the pivotal trials, and I think younger, lower risk patients really should be considered for SAVR first line, given that they may need multiple interventions in the future. And TAVR can be performed safely if there's higher surgical risk or there's no evidence of any high risk anatomy. Thank you very much.
Thank you, Dr. Chena. Oh, great speech, very extensive and detailed explanation and very detailed review of TAVR. As a cardiac surgeon, may I ask a question? I know all the TAVR is decision is made by a heart team, but as you know, in many different regions, the leader of a heart team might be a surgeon or a cardiologist. Do you think will there be some difference if the leader is a cardiac surgeon or cardiologist that any preference for surgical AVR TAVR?
Yeah, no, I think that's very important. You know, a lot of these factors enter into this is who leads the team and the financial incentive. So if people are if people are financially incentivized, also affects how, unfortunately, how the decisions get made. But I think you know, I think at least, like for instance in our center, the surgeons are a key part of the team. So the surgeons are there for the TAVR, and the surgeon. And they're part of the TAVR team, and so I think developing it as a group initiative where it's done together takes away, I think, some of the issues of the territorial nature of those decision making. And I think hopefully you know, there's obviously a lot of factors into this decision making. Cost is a fundamental issue in a lot of the world, and so whereas, you know, TAVR, you know, the cost of a TAVR is going to be much more expensive, and so there may be cost limitations in a lot of centers. But I think using that kind of combined, if we have the resources to make that best decision as a group, is really the way to go. You know, Cleveland Clinic is generally a very surgically driven field, but I think the data is very clear, and the surgeons are with us, for instance, here. So I would say for us, we're at about a 70 to 75% TAVR versus 30% surgical AVR, and in terms of our approach and treatment for these patients.
70% TAVR and 30% surgical AVR.
Roughly, yes.
Wow. Oh, okay. And my next question is from the partner 1, 2, 3 trial. As you know, more and more TAVR was done in the intermediate and low risk patients. So we do have the opportunity to follow up not only in 1 or 2 years follow up, and we have the opportunity to see what's the outcome of valve. I mean the valve outcome in about more than 5 years. Do you have any data in 10 years follow-up? Why I ask this question, because, you know, many of cardiac surgeons, including me, will consider durability of a good valve must last for example, 10 to 15 years.
Yeah.
As you, do you have any data that beyond 10 years?
We don't, because as you know, the first partner trial was presented in 2010. So we're talking about, you know, and those were all high and non-operable patients. So very few of those people are still around to have long-term data on. I think we're starting to get, so there's been recently some 8-year data presented and showing reasonable results. So, but any large-scale outcomes at this point to say that, you know, we are going to definitively, these valves don't fail at 10 to 15 years, we don't have it categorically proven. And I think as we enter into lower risk patients, and we talk about these low risk patients, you know, that's an important issue. Another issue is when you talk about low risk patients, as you're mentioning, and you're talking about a 60-year-old patient, they're going to live to 90. You're talking about possibly 2 more interventions. And so the issue with TAVR is you put in a TAVR and then you're putting a valve and a valve and a valve and another valve. And I think in those younger patients, I think surgery is also going to be even with as things go along and cost goes down, I think those are still going to be a group of patients where surgery is going to be a better choice, at least up front, potentially followed by a TAVR down the line.
Yeah. Oh. Any comments about a kind of surgical self-expandable valve done through aortotomy, such as Perseva, Intuity, something like that?
Yeah, I think those are really nice because they also give a great hemodynamics and can kind of mimic surgical outcomes and very similar to like their self-expanding valves in terms of the outcome. So our surgeons like to use the quite a bit of the Percival valves, especially on some of these patients that are high risk or they have coronary disease or other reasons for surgery. I think I think one of the things I think as a general is we've learned more about surgery since these trials than we probably knew, because now we're collecting this data and there's a lot more focus on what's the optimal surgical approaches. You know, mini AVR I think has dramatically increased worldwide with the advent of this push of TAVR and minimally invasive approaches. So I think surgery has also significantly improved in what can be offered for patients, along with as the technology for TAVR and the like have also improved.
Yeah, I personally have a very little chance to perform TAVR, as you know. Many of the TAVR was done by our cardiologists. So I personally very like to use the self-expandable valve intuitive procedure, mainly because the good hemodynamic and the morphology immediately after the operation. I can do it the minimal invasive approach. Okay, patient feel also satisfied. Okay, any comments from audience? If no other comments, thanks again for Dr. Traina. Very excellent speech. And now we'll move on the following presentation, and the following two presentations will hosted by Dr. Yu. Please.
Thank you very much, Professor Yu. And then it's my great pleasure to actually present you the third speaker of today's webinar. It will be by Dr. Masanori Yamamoto, who is from Japan. And he is going to give us a talk on decision-making in best management of aortic valve stenosis in heart failure with reduced EF. And I think this is really important, and we would like to hear from him. Dr. Yamamoto, please.
Thank you. Can you hear me? Okay.
Yes, perfect.
Okay, thank you very much. So it is such a privilege to have an opportunity to present here. Thank you very much. So first of all, this slide shows a flow chart for aortic stenosis with heart failure reduced ejection fraction treatment. And everybody knows current or classical severe aortic stenosis. It means, for example, the mean pressure gradient more than 40. And this category is aortic stenosis and heart failure with reduced ejection fraction. But we need to the etiology and severity of the aortic stenosis to define the severity of aortic stenosis, for example, by using the dobutamine stress echo. And to determine after the diagnosis of the severity of aortic stenosis, for some patients diagnosis as true aortic stenosis or pure moderate aortic stenosis. And as chairman also presented the utility of dobutamine stress echocardiography, the panel A patient in panel A shows after the dobutamine stress echo, the mean pressure gradient is increased from 29 to 52. So this patient is clearly diagnosed as severe aortic stenosis. In contrast, the panel B patient, after the dobutamine stress echo, but the mean pressure gradient is still below 40. So this patient is diagnosed as severe AS, but in contrast, the patient B is diagnosed as a pseudo AS. This flow chart clearly reveals the feasibility of dobutamine stress echo and flow chart. After the dobutamine stress echo, the stroke volume increases more than 20%. It means a contractile reverse positive. And if the patient echocardiograph shows the mean pressure gradient more than 40, it's clearly diagnosed as true severe aortic stenosis. In contrast, the mean pressure gradient is less than 40. This patient is categorized as a pseudo AS. So if the patient diagnosed as true AS, invasive treatment is generally recommended by using, for example, the surgical AVR or TAVR. And if the patient is not severe AS, the medical therapy is recommended. Also, After the dobutamine stress echo, the stroke volume is less than 20, it means the contractile reverse is negative. We need another imaging modality evaluation, for example, by using the MDCT. And if the calcium score is the volume of the calcium is abundant, the patient is also diagnosed as true severe aortic stenosis. It means recommendation or the good indication of invasive therapy, both surgical AVR and TAVI. But it's not so abundant, the patient has not so abundant calcium, the patient is diagnosed as should severe aortic stenosis and the indication of the medical therapy. So, and the stroke volume is also important in Asian cohort. And this slide shows the Japanese multi-center ocean TAVI registry, the risk factor for predicting the cardiovascular mortality after TAVR, and multivariate analysis revealed the stroke volume index is significantly associated with the increased risk of the cardiovascular mortality. And we Asian population is very small body characteristics. So the definition of the stroke volume and low flow less than 35 is adapted for small Asian cohort. In this registry data revealed the low flow evaluated less than 35 milliliter is associated with increased risk of mortality in Japanese. Also, it's also adapted in Asian cohort. So stroke volume index is 35 is a good threshold for evaluating, for predicting the cardiovascular mortality after invasive treatment. So the summarize of the phenotypes of aortic stenosis with reduced ejection fraction, we have many phenotypes. For example, the severe aortic stenosis and heart failure with reduced ejection fraction, and low flow, low gradient with low flow, low gradient. And simply the severe aortic stenosis and heart failure with reduced ejection fraction and mean pressure gradient more than 40. This patient is good candidate for the invasive treatment, both AVR and TAVR. But for example, the severe aortic stenosis with heart failure, reduced ejection fraction, low flow, low gradient without flow reserve by dobutamine stress echo, the rule out the should aortic stenosis by alternative imaging, and guideline is recommended likely benefit for AVR or TAVR based on registry data, class 2A indication ESG guideline. And most challenging field is moderate AS with heart failure reduced ejection fraction. It means a should AS or simply moderate AS, but it is very challenging and very interesting ongoing randomized trial. The TAVR unload trial is 1-to-1 randomization in patient with moderate AS, patient with medical therapy plus TAVR, and patient with only medical treatment. But these data are so limiting and wait for the results for such kind of very interesting pivotal randomized trial. Anyway, so we simplify this presentation. If a patient diagnosis as severe AS with heart failure, reduced ejection fraction, which one is better? Guideline-directed medical therapy, TAVR, or SAVR? And as everybody knows, for example, the guideline or some recommendation, diuretics for heart failure or nitrates and beta blockers for angina. Summary of useful medical treatment in valvular disease shows. However, the diuretics may also reduce the cardiac output and worsening fatigue, and beta blocker and nitrates cause symptomatic hypertension, especially in their use shortly after exertion. So pharmacological therapy may be limited in the setting of severe AS with reduced ejection fraction. And previous pivotal several landmark trials in patients with heart failure reduced ejection fraction excludes the hemodynamically significant aortic stenosis, we don't have enough data. And in contrast, the TAVA, or of course SAVA, is superior compared with guideline-directed medical therapy, which includes the palliative therapy, balloon aortic valvuloplasty. The previous partner trial shows the superior or better outcome in TAVA patient compared with standard therapy. It means a guideline-directed medical therapy and including the balloon aortic valvuloplasty. So we know the limitation of medical therapy for aortic stenosis patients and balloon aortic valvuloplasty. I would show the case. 80 years old female patient, she complains of dyspnea and the symptom is worsened, and admitted to our hospital, the exacerbation of heart failure. And the chest X-ray also shows a cardiomegaly and pulmonary edema and pleural effusion. Electrocardiogram shows sinus rhythm plus APC and tachycardiac state. And the echocardiography shows a low ejection fraction. Calculated EF is 40%, but the mean pressure gradient is 90. It's so severe, very severe states. So patient prognosis is diagnosis of acute heart failure with severe AS, and NPPV and diuretics and catecholamine was started after admission, but the heart failure was worsening. Now, after 10 hours from hospitalization, the patient complicated with worsening of heart failure and symptoms again, and leading to the cardiac arrest. The patient was transferred to cath lab, and ECMO, PCPS, and IABP were inserted. Afterwards, coronary angiography was performed. Unfortunately, the coronary angiography shows three vessel disease in the right and left coronary artery. So we choose palliative therapy using the balloon aortic valvuloplasty, and mean pressure gradient significantly decreased, but it's not enough, from 90 to 50. And revascularization for the coronary artery disease is completely done. However, and after the valvuloplasty, the echocardiogram shows still severe stenosis, severe aortic stenosis. And this patient prognosis is patients underwent PCI for three vessel disease and VAV for severe aortic stenosis. And the ejection fraction is improved from 40 to 53%. And severe aortic stenosis is still severe, but it improved. Mean pressure gradient 90 to 67 were improved. On the first operative day, the patient was hemodynamically stable without ECMO and IABP. However, the patient level of consciousness was good, and TAVI was scheduled after the contrast CT. On the second post-operative day, sudden hypertension and bradycardia developed, leading to PEA again. And cardiopulmonary resuscitation was unresponsible, and the patient did not wish to have PCPS inserted again. So this patient is dead. In contrast, TAVA or SAVA invasive therapy is useful in patients with AS and reduced heart failure with reduced ejection fraction. This is a 95 years old female, it's very high age. And chest X-ray also showed the pulmonary edema and pulmonary effusion. And electrocardiogram shows the tachycardiac state, and saturation value is 87. And coronary angiography shows no significant stenosis. But transthoracic echocardiography shows a severe aortic stenosis, and severe mitral regurgitation. And left ventricular ejection fraction is 38%, is 95% of patients, acute heart failure. So we should stop the invasive therapy. And respiratory condition is deteriorated during the CAG. And she was intubated under the mechanical ventilation. Which treatment do you choose? And the lactate is significantly elevated, 10.9, and the ejection fraction is 38, and extremely small body. So we have no choice for this patient. Probably the palliative care or best supportive care is considered, but her family and we choose the TAVR, emergent TAVR for this patient. And this is contrast CT findings before the procedure. And aortic valve complex shows a relatively large amount of the calcium on the aortic root, but it's suitable for TAVR. And we did the TAVR via transfemoral with stiff wire, and S3 choose the Sapien 3 valve, but ECs did not cross. By changing the dry shield, S3 was able to pass through the dry seals without no resistance. It is a technical point. And finally, the Sapien 3 23mm implantation was successfully deployed without any complications. And aortic stenosis is completely improved. This is a final angiogram. No aortic regurgitation, no severe stenosis. And surprisingly, the functional MR is completely disappeared after the TAVR procedure. It's very interesting. And this patient, so the TAVR treated severe aortic stenosis and severe mitral regurgitation. So, generally recommended, we should not postpone the emergent procedure, emergent invasive procedure, delayed BAV or TAVI in emergent cases worsens the prognosis by previous reports. And which is better, emergent TAVR or palliative emergent BAV? So, of course, the early mortality and late mortality is still high, but emergent TAVR or TAVI is superior compared with the BAV treatment. So that is the reason why we choose TAVR compared with medical or BAV therapy. So my final answer is decision-making in best management of AES patients in heart failure with reduced ejection fraction. I think the guideline medical therapy is firstly selected, plus TAVR or SAVR. So next question is, which is better, TAVR or SAVR? The previous pivotal partner trial showed the equivalent or superior outcome in TAVR compared with SAVR treatment. But this sub-analysis focused on the ejection fraction. We have no data concerning the reduced ejection fraction. The sub-analysis only focused on the cutoff range of the ejection fraction, 55, 55, and 65. So we don't have enough data. The reduced ejection fraction, for example, less than 50, less than 40. And this slide shows the previous reports concerning the results of the reduced ejection fraction patient with AS. This is the SAVR data. And we have not enough data concerning the TAVR results. In summary, the mortality of AS with heart failure reduced ejection fraction. The SAVR data shows the early 30-day mortality is reaching 5 to 15%. And late, it means, for example, 5 years, the mortality is 25 to 50%. In contrast, the TAVR shows the early results of mortality is approximately 4 to 8%. It's comparable between the SAVA and TAVA. And rate mortality, we don't have enough data, long-term outcomes of TAVA. So data is still limiting in this field. And this is a current recommendation of ACC/AHA ESC guideline. It still determined considering the traditional surgical score, for example, the STS score, and patients were divided in low, intermediate, high, and extreme risk. And decision making, which is better, TAVA or SAVA, is determined based on the surgical risk score. But I think, what should we do as a next step? In the risk stratification beyond the surgical risk score probably we need a TAVA-specific risk model to evaluate and appropriate candidate between TAVA and SAVA. For example, the limitation of the traditional surgical risk score, patient categorized low risk score, STS less than 4%, 70 years old patient, for example, the liver disease or hematologic disease. This patient is truly the high surgical, not a surgical risk. No, this is a very high surgical risk, but STS score is still less than 4%. And 80 to 90 years old patient without comorbidities, of course, this patient is a low surgical risk, but this patient is not a good candidate for SAVA. I think this patient is a good candidate for TAVA. And intermediate risk patients, the 60 to 80 years old, younger generation with a few comorbidities, not a good candidate for TAVA. We need a more long-term data. Of course, ASEAN cohort, the life expectancy is significantly longer compared with Western people. So I think we should focus on the limitation of traditional surgical risk scoring. And this is the data from Ocean TAVI registry in Japan. And if we divided the patient prognosis based on the surgical risk score, low, intermediate, high, but the traditional surgical risk score is not useful for evaluating the risk stratification concerning the late mortality. Low and intermediate risk, there is no significant differences in the mortality rates up to 2 years. So we should divide it only simply low and intermediate risk should be categorized under one category, high or non-high risk patients. In addition, we need in the real world the true risk stratification for predicting. For example, I provoked the 1-year mortality risk model after TAVA. We need the information for gender, BMI, clinical frailty scale, atrial fibrillation, blah, blah, blah. We can calculate the risk for evaluating the 1-year mortality after TAVA. And for example, such using a true risk model, the patient risk stratification is more useful. Anyway, so this is my concluded slides. The best management of AS in heart failure is reduced ejection fraction. Beyond the surgical risk score, we should consider the risk-benefit balance between the TAVA and SAVA, and the best appropriate treatment should be determined, plus the guideline-directed medical therapy. Thank you for your kind attention.
Thank you very much, Dr. Yamamoto. That's really insightful and good sharing that you have. I have, let me start with maybe one question. As you know, patients with reduced EF can have, because of severe aortic stenosis, they can have concomitant coronary artery disease. So in this group of patients with concomitant coronary artery disease, the first question is, how do you determine which takes predominance of the symptoms, and how would you then approach whether to do valve first or to do aortic valve inspection?
Sorry, I can't hear clearly, please.
Oh, sorry. So my question is, concomitant coronary artery disease in patients with severe aortic stenosis, in patients with reduced EF is very, very common or prevalent. How do you know whether the symptoms is related to coronary artery disease or severe aortic stenosis? And if so, which intervention would you go for? The revascularization approach first?
Thank you. Very important point. I think the improvement of ischemia is determined by the FFR, the physiological findings, based on the physiological findings. It's not a clinical, it is very difficult to distinguish the symptom is truly originated by AS or coronary artery disease, but the improvement of the ischemia is determined by the FFR study. And if the FFR study is not so significant, I think the AS treatment is first. Thereafter, the coronary artery disease is treated. But if the ischemic territory is very large and the significant FF value was proven, I think the coronary artery is first treated. Thereafter, the TAVI or surgical AVR is considered. But in surgical cases, CABG plus AVR is generally recommended. Thank you.
May I join the discussion?
Yes, please. I actually wanted to invite you to.
I feel very interesting about your question. Yes, for patients with severe AS, low ejection fraction, always associated with coronary artery disease, you know, but we cardiac surgeon, we want to very extensive operation to solve the aortic valve disease, that is AVR plus cabbage. A complete revascularization might be the best way to save him, as you know. So always very long operation time. That means very long bypass time. That means very long, very big myocardial edema after the operation. So with difficult postoperative cause, many times with surgical mortalities, you know. Okay, that's the early years, about 10 years ago, the usual scenario for this poor case. And now in our hospital, we use ECMO. Our hospital has relatively many ECMO experience for postoperative support. And usually we do still the same operation, complete operation once to save his life is our best hope. And supported by ECMO roughly for 5 days or 7 days after the operation, then the condition gets stabler. We remove the ECMO, patient recover gradually from the operation. And if they can recover, they can improve. The critical period is about 1 week. That's my personal experience. That is a very interesting question. Thanks again.
Yeah. Can I ask you further? Because I wanted to ask you, do you have any experience telling us which are the group, or actually these questions can go to both speakers, both panelists here, which patients would you approach it by a palliative approach? Which means, is there any parameters or clinical features that you will say you will not touch surgically, so that the transcatheter team will then take over and help the patient?
I can answer it very quickly and briefly. You know, in the recent 2 years, our cardiology did a good help for us. Why? Because most of the TAVI was done in our hospital by our cardiologist. And for this case, we provide ECMO support as a backup. They do the TAVI. That's really a teamwork, as you know. And maybe they add a coronary standing, you know. And postoperative, if we partially solve the critical condition of aortic stenosis and everything gets stabilized, ECMO support, and we can do things step by step. That means a stage operation for this poorly patient. The bridge, we use ECMO as a bridge to get better results. That's our personal experience to share with you guys. I would like to hear the opinion from Dr. Yamamoto and from Dr. Yo. Thank you.
Dr. Yamamoto, you have any experience in the patients that you will say, you know, we're not going to treat you, and all those that you do not want to send for in any interventions? I think he can't hear us right. Can you hear us, Dr. Yamamoto?
Yes, okay, sorry.
Yeah, no, I think we were discussing which are the group of patients that we will think a palliative approach will be a acceptable one. What are those parameters that you will share with our listeners, that which are the ones that you know they're not going to do well? Or you should treat everyone?
Yeah, so
in our country, economic issue is still a very big problem, to be honest with you guys.
Yeah, maybe I can share. Actually, for us, the same. You know, if we find a problem, and unless we are not going to change the prognosis or the clinical status of the patient, for example, if the patient is physically very mild and not able to have a quality of life, then we should really, you know, be palliating the patients with medical therapy, even if you find a true severe aortic stenosis, because we know it's not going to change very much. But this is my personal stance, because you know that if you do perform a good TAVR in such cases, you probably can prolong the survival of the patient for at least 12 months. But if 12 months is with patients who's not able to enjoy the quality of life, it's something that is probably debatable. I think we have very good discussions on this very particular group of patients. I think we should move on to our next speaker. Thank you very much again, Dr. Yamamoto, for sharing your talks and experience. Let's move to the last speaker. I have the pleasure to invite Dr. Lau, who is a cardiologist from Brunei, and she's going to share with us the timing of surgical intervention for severe aortic regurgitations. And Dr. Lau, please.
Yeah, hi. Thank you. Thank you, Prof. Nice to meet you again. Good evening, everyone. This is I'm Lau Bingo from Brunei Darussalam. My talk is on the timing of surgical intervention for severe aortic regurgitation with rheumatic or non-rheumatic mechanism, any point of no return. Aortic regurgitation is reported in up to about 15% of adults, and after mitral regurgitation and aortic stenosis, it ranks third in the prevalence amongst valvular heart disease. And its prevalence increases with advancing age, ranging from about 5% in the population in those younger than 50 years of age to about 16% in those older than 70 years of age. And now a shift in the age distribution towards an elderly population will likely amplify the burden of aortic regurgitation to the healthcare in the future. The older literature actually reported a very low mortality rate of 0.2% per year in asymptomatic patients, but recent data have suggested that this mortality rate is not that benign. It's up to about 2% per year in asymptomatic patients. On the other hand, symptomatic patients have high mortality rate. Now, the etiology of the aortic regurgitation can be related to either a leaflet and or aortic root pathology that can be acquired or congenital in its origin. Aortic regurgitation can be associated with a degree of arthropathy in most instances, and so the assessment of the aortic root and ascending aorta is integral in the assessment of aortic regurgitation. Now, with the advent of aortic valve repair, understanding the mechanisms of aortic regurgitation is important. And broadly speaking, there are three types of aortic regurgitation, with type 1 and type 2 being more amenable to successful aortic valve repair. Most patients with indications for surgery in severe aortic regurgitation will require either a mechanical valve or bioprosthetic valve. However, valve repair is actually possible in a selected number of patients. And although the approach of primary aortic valve repair is not yet generalizable and its durability is not known, excellent medium-term results have been reported when it was performed in high volume and highly specialized centers. And a meta-analysis has actually shown the in-hospital in 1 year mortality rate was comparatively lower in the repair cohort as opposed to those patients with aortic valve replacement. And it has also been reported that the 10-year rate of valve-related complication was considerably lower after having aortic valve repair. And this is because of freedom from long-term anticoagulation, more physiological valve function, and lower risk of endocarditis. Now, I'm going to be talking about the timing of surgery for significant aortic regurgitation. And traditionally, as we all know, this has been guided by the presence of symptoms, left ventricular function, and left ventricular dimension. Now, I'll also be touching on some of the other parameters that can be used in decision-making in timing the surgery for significant aortic regurgitation. And these are left ventricular global longitudinal strain, or LVGLS, brain natriuretic peptide, or BNP, and myocardial fibrosis, and exercise TAPSE, or tricuspid annular plan-systolic excursion, which is a marker of right ventricular function. In the management of aortic regurgitation, the 2017 ESC and EACTS guidelines, they consider the diameter of the ascending aorta first. They recommend surgery when the diameter of the aorta is between 4.5 to 5.5 centimeters, and depending on the etiology of the aortic dilatation, regardless of the severity of the aortic regurgitation. Next, when it comes to significant aortic regurgitation, the timing of surgery is guided by 1, the presence of symptoms, and 2, by left ventricular dysfunction. And these are class 1 indication for surgery. However, on the other hand, in patient having asymptomatic severe aortic regurgitation, the timing of surgery will be guided by left ventricular dimension. And this is defined by left ventricular end-systolic dimension that is greater than 5 centimeter, or an index left ventricular end-systolic dimension that is greater than 2.5 centimeter per meter square, or a left ventricular end-diastolic dimension that is greater than 7 centimeter. The latest American guidelines are more or less consistent. However, I just want to highlight a few points. They have now redefined the left ventricular dysfunction cutoff value as to less than 55%. And in American guidelines, having a left ventricular end-diastolic dimension of 6.5 centimeter is a class 2B indication for surgery. And one unanswered question is the timing of surgery for rheumatic aortic regurgitation. And most of the recommendations for surgical management of severe aortic regurgitation for rheumatic aortic regurgitation have been extrapolated from data on non-rheumatic aortic regurgitation. Now, the timing of surgery for severe aortic regurgitation, the timing of surgery for severe aortic regurgitation is clear for patients having symptoms and left ventricular dysfunction, and these are class 1 indications. However, on the other hand, the timing of surgery is actually controversial for patients having asymptomatic severe aortic regurgitation and preserved left ventricular function, where traditionally left ventricular dimensions have been used to guide the timing of surgery. And there is actually evidence out there to suggest that when current guideline surgical threshold set in, that is symptoms and left ventricular dysfunction, there is already irreversible myocardial damage that can persist after surgery, and that the post-operative outcomes are actually worse for these patients. So in this study conducted by Mentius, in patients having significant severe aortic regurgitation with preserved left ventricular function, having no or minimal symptoms, they found that patients having aortic valve surgery had better long-term survival with a life expectancy that is comparable to that of a normal matched US population. And these authors also found in the non-surgical group that the risk of death significantly and continuously increased when the index left ventricular end-systolic dimension was greater than 2 centimeter per meter square, a threshold that is lower than the current recommended value of greater than 2.5 centimeter per meter square. And these authors also reported that symptomatic patients actually had a 2-fold increased risk of mortality as compared to asymptomatic patients. Now, the findings of Mencius were actually corroborated by the study conducted by Demister, who showed that the adjusted 10-year survival for those patients undergoing aortic valve surgery for severe aortic regurgitation, the adjusted 10-year survival was better among patients without operative triggers or with class 2 triggers than when compared to patients having class 1 triggers. And these authors also found that freedom from hospitalization for heart failure was actually better in those patients who were operated before the onset of class 1 triggers. And similarly, these authors also found that mortality increased when the index left ventricular and systolic dimension was greater than 2 centimeters per meter square. And in this landmark study conducted by Young in Mayo Clinic, where they were able to compare both surgical and non-surgical patients, there were a higher number of deaths in the non-surgical group. And these authors found again that the index left ventricular and systolic dimension was inversely proportional to all-cause mortality in both the operated and the non-surgical group. And here, having an index left ventricular and systolic dimension of greater than 2.5 centimeters per meter square was actually conferred a increased risk for all-cause mortality. And in the ventricular and systolic dimension of greater than 2.5 centimeters per meter square, and having left ventricular dysfunction was associated with increased risk of mortality. Now, so it seems that a lower index left ventricular and systolic dimension that is greater than 2 centimeters per meter square appeared to be indicated for earlier timing of valve surgery for severe aortic regurgitation rather than the one that is recommended in the current guideline, which is set at greater than 2.5 centimeters per meter square. Now, moving on, I'm just going to be touching on GLS, which is global longitudinal strain, and talking about left ventricular global longitudinal strain. This is actually a marker of subclinical myocardial dysfunction, and it can actually detect subendocardial myocardial fibrosis before deterioration of left ventricular function. And these authors actually looked at patients having severe aortic regurgitation with preserved left ventricular function and found that the LVGLS was actually worse than the defined threshold of minus 19%. So this paper, they actually looked at 1,000 patients having asymptomatic severe aortic regurgitation, having preserved left ventricular function and an index left ventricular and systolic dimension of less than 2.5 centimeters per meter square. And they found that unoperated patients having worsening of LVGLS of worse than minus 19% had actually high mortality. And these same authors also looked at the value of baseline and follow-up GLS in patients having aortic valve surgery for asymptomatic severe aortic regurgitation and preserved left ventricular function. And they found that the baseline LVGLS was worse than 19% was associated with reduced survival. That is, it can actually prognosticate. And in those group of patients who underwent surgery, who returned for post-operative follow-up, they also found that persistently impaired LVGLS was associated with increased mortality. And this authors also concluded that an LVGLS, a drop of LVGLS of 5% from baseline to follow-up was associated with reduced survival. Now, moving on, I'm just going to be touching on this mixed aortic valvular disease and the use of LVGLS in predicting as a risk predictor. As we all know, aortic regurgitation can be associated with a degree of aortic stenosis, and this paper is interesting in that it looked at whether LVGLS can be used to risk stratify patients having mixed aortic valvular disease. And again, this paper actually showed that LVGLS was an important predictor of mortality with a value that is worse than minus 15%, conferring a higher risk of mortality in these patients. Now, there was this paper discussing the role of TAPSI in predicting the need for aortic valve surgery. So this paper actually looked at the role of exercise TAPSI in decision-making for asymptomatic severe aortic regurgitation patients having preserved left ventricular function. And they found that exercise TAPSI was significantly reduced in patients having severe aortic regurgitation. So essentially what this paper sort of went on to say was that exercise TAPSI, or tricuspid annular plane systolic excursion, which is a marker of right ventricular function, essentially what it says is that exercise TAPSE was an independent predictor of the need for aortic valve surgery, and suggested that exercise TAPSE may be used in decision-making to decide whether a patient goes for earlier surgery for severe aortic regurgitation. Now, B-type natriuretic peptide and N-terminal pro-B-type natriuretic peptide, these are neurohormones that actually they result from the breakdown of pro-BNP, and they're actually neurohormones that are primarily released from the ventricular myocardium in response to increased myocardial wall stress that can be seen in chronic aortic regurgitation. And what this paper found was that the BNP can actually predict the risk of disease progression for patients having severe aortic regurgitation at the subclinical level. And they also found that persistent BNP elevations during serial follow-ups, persistent BNP elevations were associated with worse outcome of left ventricular dysfunction, heart failure symptoms, and death after a duration of about 15 months. Prof, you touched on CMR in assessing aortic regurgitation severity. So there's this paper that looked at the role of cardiac MRI to reclassify the severity of aortic regurgitation severity. Now, CMR can be used to quantify aortic regurgitation severity in cases where the echo examination is suboptimal or when the clinical findings do not correlate with the echo findings. And this is actually recommended in the present guideline. So in this paper, with 40 patients having moderate to severe aortic regurgitation on echo, they were found, nearly 50% of them were found to have severe aortic regurgitation on MRI by the presence of hollow diastolic retrograde flow seen in the descending aorta. So essentially, on the other hand, 34% of patients having severe aortic regurgitation on echo, they were found to have non-severe aortic regurgitation when MRI was done. So essentially, cardiac MRI can reclassify the severity of aortic regurgitation. It is fast and feasible and easy to do. However, it's not available in all centers, and CMR can actually complement echocardiographic AR assessment in cases where the echo examination is suboptimal or when difficult clinical decisions need to be taken. And on the other hand, the presence of hollow diastolic retrograde flow seen in the ascending aorta, in the descending aorta, was shown to be associated with an increased risk of adverse outcome in patients having severe aortic regurgitation. Now moving on, I'm just going to be touching on this T1 mapping technique to diagnose diffuse interstitial fibrosis. Now, chronic aortic regurgitation leads to left ventricular remodeling, which is associated with two forms of myocardial fibrosis, regional replacement fibrosis and diffuse interstitial fibrosis. So the presence of fibrosis actually indicate disease progression at the subclinical level. And as we all know, regional replacement fibrosis can be conventionally diagnosed by the use of lead gadolinium enhancement on MRI, whereas this so-called diffuse interstitial fibrosis or reactive fibrosis can only be picked up by these so-called T1 mapping techniques. And this paper, which was recently published in JAG Imaging, it looked at the role of diffuse interstitial fibrosis using T1 mapping in patients having severe aortic regurgitation. And from doing pre-contrast T1 and post-contrast T1 images, they were able to derive this so-called indexed extracellular volume. And what they found was this indexed extracellular volume, or index ECV, correlated with the severity of aortic regurgitation. In other words, index extracellular volume significantly increased with the degree of severity of aortic regurgitation. So the index ECV, or index extracellular volume, actually measures the absolute volume of left ventricular myocardium that is in the extracellular space divided by the body surface area. And what it actually measures is that it actually measures the total left ventricular interstitial fibrosis burden. And in this paper, they found that index extracellular volume of greater than 24 mils per meter square and an aortic regurgitant fraction of greater than 30% as detected on MRI was associated with the highest event point of a composite endpoint of death and aortic valve replacement. So essentially, this paper went on to say that the index in extracellular volume can predict the need for aortic valve surgery. Now, moving on, the surgical mortality has been reported to be low recently. I mean, over the last 30 years, the surgical mortality rate has reduced significantly, such that it is now lower than 1%. And this is due to advanced surgical techniques, including aortic valve repair and minimally invasive aortic valve surgery, and also due to improved intra-operative myocardial protection and improved post-operative care. So now that surgical mortality is low and that aortic valve repair is possible, and with the valuable evidence to suggest that one intervenes earlier for severe aortic regurgitation. So intervening earlier in the course of severe aortic regurgitation appeared to be beneficial. However, shared decision-making and discussions between the risk of early surgery versus the risk of delaying surgery, and also discussion and between the trade-offs between aortic valve replacement and aortic valve repair is essential. So in the assessment of aortic regurgitation to determine whether aortic valve surgery is required for patient, firstly, one needs to assess the severity of aortic regurgitation, and traditionally this can be done on echo and can be complemented by CMR when echo examination is suboptimal, or when clinical data is equivocal, or when the clinical findings do not correlate with the left ventricular function. Now, left ventricular GLS, as mentioned, is a marker of subclinical myocardial dysfunction, and it can be used also in decision-making for the timing of surgery for aortic regurgitation. A value that is worse than -19% has been shown to be associated with reduced survival. And thirdly, one needs to assess the left ventricular dimension in systole. So the current surgical threshold is set at greater than 2.5 centimeter per meter square. However, data is emerging that a threshold value of greater than 2 centimeter per meter square is associated with the increased risk of mortality. And fourthly is to assess for the presence of arthropathy, which is commonly associated with aortic regurgitation. And this can actually guide the timing and the type of surgery to be used. And next comes MRI and BNP, and this can be used in the clinical follow-up of patients. MRI to assess for the presence of myocardial fibrosis, and then also to reclassify aortic regurgitation severity in cases where it wasn't clear on echo, and BNP also to help detect the risk of disease progression at the subclinical stage. So to conclude, there's data out there to suggest that there's possible long-term survival benefit from the earlier timing of aortic valve surgery for patients having asymptomatic severe aortic regurgitation and having an index left ventricular systolic dimension of greater than 2 centimeter per meter square. Just to highlight that these are all observational data, and so they haven't been included in the present guidelines. Myocardial fibrosis detection by CMR can be used potentially to re-stratify patients having severe aortic regurgitation, and perhaps can justify earlier surgical intervention before extensive fibrosis and irreversible myocardial damage develops. And then BNP and NT-proBNP levels can also be used to follow up patients, essentially to identify patients at high risk of clinical progression. Thank you.
Thank you very much, Dr. B. I think that was really comprehensive, and we now know how to and when to use all these markers. Can I ask a very simple question?
Yeah.
I'm a clinician who looks after patients with chronic aortic regurgitation. The patient is asymptomatic, but I know that on echo, the LV is dilating. What should you follow up test with, and what will be the test, and what are you looking out for?
Sorry, Prof, I missed the last part of your question. The LV is what, sorry?
The LV is dilating, but it hasn't hit the target guidelines recommended therapy, and the patient claims to be asymptomatic. What tests are you going to order, and what are you going to tell me?
Oh, okay. So essentially what we can use to monitor this patient is, one of the other things that I actually didn't mention in the talk is to use exercise echo. I actually didn't mention in my talk, but I suppose exercise echo can be used to re-stratify these patients to elicit for symptoms, and also to look for contractile reserve. I suppose if patient is if stress echo is able to elicit symptoms, it sort of suggests that this patient has latent elbow dysfunction. And on the other hand, we can also use BNP to monitor this patient. If the BNP level is, or BNP or the NT-proBNP levels are raised, I suppose, at the end, we can use all these markers to help us in decision making for timing of surgery for this patient.
Thank you. I think that's really comprehensive. I mean, I think the important thing is what are the most sensitive markers or parameters we can trust for detections of LV systolic dysfunctions in a patient who is asymptomatic. And the truth is that there are many markers that we can detect, and a lot of the data are really on retrospective database. So in prospective database, where you have a core-lag adjudications kind of parameters, it may be something that's helpful. I use clinically in the lab also on GRS, but I find that can be variability between studies to studies. So an independent way of looking at the GRS may be helpful. I think CMR is great, but CMR in my mind is very expensive and you can't do it on a yearly basis for someone who is totally asymptomatic. So I like your idea of actually looking at the clinical status and following up with the patient that say, look, if there's any difference in your effort tolerance, perhaps we can have a closer monitoring, something that you can trust. And in our lab, most of the time, we actually look at the LP end-diastolic diameter because that is quite reproducible. And when there is a little bit of inconsistency, then you go on and do a CMR. I like as well the proBNP because proBNP is the biochemical way of suggesting that the LV has shown sign of decompensations, and I do monitor them. So in conclusion, for me, I probably will just look at the patients in clinical status, and number 2, biomarkers, which is really cheap, and third is just looking at the LV function in GRS. Dr. Yu or Professor Lee, from surgeon perspective, what do you think is important in this group?
First, I have to thank Dr. Lau to tell me the LVGRS. I don't have many experience in that. Regarding the severe regarding the aortic regurgitation with severe LV dilatation, sometimes we have to deal with this patient. As you know, they can recover from the operation frequently. You do the LT-AR case with LVEDD, for example, 65 millimeter. The immediate postoperative is satisfactory, but they not always frequently come back 1 or 2 years because of end-stage heart failure needing BAD or heart transplant. So in my clinic works, I will do MRI for this case, trying to use T1 mapping, as you just tell me, to find the interstitial fibrosis, because I believe LV dilatation will induce some microscopic change of microscopic interstitial fibrosis that will make things irreversible, But as Dr. Yo, it's relatively expensive, and many patients can't stand the procedure. You have to lie down for 30 minutes for a complete MRI study. So I feel very nice to hear you that LV longitudinal strain might be contribute to differentiate the which one is reversible and which one is irreversible. I think it's nice. I will study it in my clinical works. Very thanks for your great speech. I learned very much. Great.
Yeah, I think I wonder whether there are other questions from the panel. Otherwise, I think that was truly four wonderful talks that really educate us on the aortic valve, valvular diseases, go from aortic stenosis to aortic regurgitation, when to intervene, and in patients with difficult decision making in impaired LV function. I have enjoyed today's talk, and the speakers are great, and it was wonderful listening to them. And my chairman, Professor Yu, was excellent. He asked very important questions. Not only that, he's very experienced. He shared with us his personal surgical experience. And I think that really adds weight to our webinar.
Thanks, Dr. Yo, for your welcome comments. And again, I have to thank all the speakers as well as all the audience to join us for this very comprehensive, educative, informative, very nicely committee. Oh, thanks again for APSC committee to have this meeting for us. Great.
Thank you, everyone. Stay safe.
Okay.